Module 10, Experimental Studies. In Modules 8, 9 and the first part of 10, we have reviewed different epidemiologic study designs. These were observational designs. In these studies, the researcher observes and systematically collects information, but does not try to change the individuals being observed. Observational studies can be descriptive or analytic. Another category of analytic designs are experimental studies. By contrast, the investigator intervenes to change something, like gives some patients a drug, and then observes what happens. Consequently, experimental studies are referred to as intervention studies. During several of the previous lectures, I've stated that one of the challenges faced by epidemiologists is the lack of control they have over their subjects and variables in the study. Experimental studies is as close as epidemiologists can get to creating a controlled laboratory environment. The actual design of an experimental study is similar to a prospective cohort study, but instead of the exposure being measured and subjects followed over time, the exposure is allocated and subjects are followed. In well-designed experimental studies, the degree of confidence in the validity of the results is higher than any other epidemiologic study design. The hierarchy of evidence ranks study designs according to the validity of their findings. Of course, we always try to use the best possible design, but sometimes this is not practical or ethically acceptable. You can't do an experiment to expose some people to a harmful substance to see what effect it has on them. Randomized controlled trials and meta-analyses of the results of such trials are ranked the highest and provide the strongest support for a causal association. There are three types of experimental study designs, most commonly the randomized controlled trial, and we will focus on this design for the rest of the lecture. In RCTs, the unit of analysis is the individual, but sometimes this is not practical, or the intervention is a group-level intervention. For example, the study of the dissemination of the Canadian Critical Care Nutrition Guidelines involved a multifaceted educational strategy targeting staff working in intensive care units. The education was around the importance of nutrition and implementing various bedside strategies such as algorithms, protocols, and pre-printed order sets to improve nutrition provision to patients. As this educational strategy targeted the ICU, instead of randomizing individual patients and assessing their nutrition intake, ICUs or hospitals were randomized to either receive the education or continue as normal. These studies are called community trials or cluster randomized controlled trials. Natural experiments are unplanned situations whereby individuals become exposed, resembling a planned experiment. Recall back in Module 1 the description of John Snow, one of the forefathers of epidemiology, and his investigation of the cholera outbreaks in London. Recall also from the first module this gentleman, James Lind. He is often credited with pioneering experimental epidemiology through his systematic approach to treating scurvy in British soldiers. We will be focusing on a more recent example of a randomized controlled trial, actually a study that I was involved in, a trial of glutamine and antioxidants in critically ill patients called the REDOX study. As with any study design, the first step is to define a research question or hypothesis. Depending on the focus of the study question, the trial may be clinical, that is, evaluating the efficacy of a new procedure or drug, usually in patients, prophylactic, that is preventative, or therapeutic, which is similar to clinical in that it looks at new treatment methods. The research question or hypothesis must be supported by strong scientific background and a clear rationale. The background may include evidence from observational analytic studies or smaller trials. The ethical foundation for conducting an RCT is also that there exists clinical equipoise. That is, that there is genuine uncertainty over what the optimal treatment is. In our example, the The study question was, does the administration of high doses of the amino acid glutamine and antioxidants modify oxidative stress and reduce mortality in mechanically ventilated critically ill patients? The next step is to define the study group. Investigators start by defining the reference or target population, which is the population to which they want to be able to generalize the results of the study. This definition may incorporate demographic and disease descriptors if the outcome is associated with these variables. The reference population is often a theoretical population, that is, there's no sampling frame per se. The next step is to select the study sample, which becomes a practical representation of the reference population. This sample can be identified and counted, must be large enough to produce enough outcomes, may be restricted to increase compliance and improve accuracy of the data. Investigators develop a clear eligibility criteria to aid in selecting appropriate individuals. Eligibility criteria include inclusion and exclusion criteria that optimize conditions for a successful study. In creating the eligibility criteria, investigators consider the study objectives, anticipate possible threats to internal and external validity, consider potential harm and benefits to the subjects, as well as consideration of efficiency and convenience. In our example from the redox trial, the inclusion criteria were that patients must be mechanically ventilated, that is, on a respirator, be greater than 18 years old and admitted to the ICU, and they must have 2 or more organ failures related to their acute illness. So these are really severely sick patients at a very high risk of mortality. The following patients were excluded from the redox study: those who had been in the ICU for greater than 24 hours, patients who were moribund, patients for whom there was a lack of commitment to full aggressive care, where there was an absolute contraindication to enteral nutrients, where they weighed less than 50 kilograms or greater than 200 kilograms, if they were pregnant or lactating with the intent to breastfeed, and if they were previously randomized into the same study or a related ICU trial. Research staff involved in the study identify individuals within the experimental population, that is, they meet the eligibility criteria, and then approach them to participate in the study. Strict ethical standards are in place to ensure that individuals are provided with adequate information about the study, including the risks and benefits, and that they have an opportunity to ask questions. This is so that they can provide informed consent for participation. This is problematic in the ICU setting in which the redox trial was conducted, because the patients are sedated and ventilated and in no state to provide consent. In these circumstances, a surrogate decision maker, such as their spouse, parents, children, provide consent on enrolment. The experimental population, excluding those who decline to participate, provides the study sample. In the redox trial, 5,633 ICU patients were assessed for eligibility. Of these, 3,350 were excluded because they did not meet the eligibility criteria, providing an experimental population of 2,283. 1,060, or 46% of those eligible, did not participate in the study, mainly because of lack of consent. Non-participation in an RCT does not introduce a bias. However, it may limit the external validity of the study. The data in the flow diagram illustrates the effect that non-participation can have on the sample size of the study. Investigators employ several strategies to optimize sample size. Losses to follow-up may be minimized by pilot testing of recruitment and follow-up strategies. Investigators ensure a large enough experimental population through multi-center studies. They may also ensure a high number of events by targeting groups at high risk of the outcome, or include longer follow-up to observe more events. An individual recruited into the study is then randomly allocated into the treatment or control arm. Random allocation of the intervention occurs after subjects have agreed to participate and provided informed consent. Random assignment helps to assure each subject has an equal probability of being assigned to either the experimental or control group. In the redox trial, patients were randomized by a centralized computer-generated randomization scheme. Randomization schemes were controlled by a pharmacy, and the random code was kept in an opaque, sealed envelope. So what is the purpose of randomization? Randomization achieves balance on known outcome predictors and also balance on unknown outcome predictors, and thus ensures groups are alike except for the intervention. Threats to the success of randomization are if the process is not centralized, if there's small numbers leading to chance imbalances, or non-compliance, such as side effects differ between the two arms of the trial. A strength of randomization is that it eliminates selection bias and confounding, so barring measurement errors, differences in groups other than the intervention should only be due to sampling error. In the redox trial, stratified randomization was employed, whereby patients are categorized into strata based on specific variables, in this case, ICU site and presence of sepsis, and random allocation is performed within the strata. Stratification increases the probability that experimental and control groups are similar with regard to important confounding factors, and can also be used to detect effect modification in a study by assessing treatment effectiveness within strata, such as evaluating if the association is different in patients with and without sepsis. This is dependent on the sample size and that it's large enough within each strata. The intervention is then applied. And here is the first patient that was enrolled in the redox trial back in 2005. And of course, when this photo was taken, we did not know if this patient was allocated to the intervention or control group. But you see in this photo the bag hanging of orange liquid, which could be the study nutrients or the placebo nutrients. The control, comparison group, will receive usual care or standard treatment if such a thing exists. If there is no current intervention, a placebo is used. Placebo is an inert substance or treatment that has no effect, and we use a placebo rather than nothing because of the placebo effect. That is, the tendency for those receiving a treatment to experience beneficial effects even if the treatment has no known therapeutic benefits. I mentioned that when the photo of the first patient enrolled in the redox trial was taken, the allocation was unknown, and this is because of so-called blinding. Single-blinded study is when study subjects are unaware of their group assignment. A double-blinded study, which is the most common design for RCTs, is when both subjects and investigators are blinded. Triple-blinded studies are when subjects, investigators, and analysts are blinded. If subjects are unblinded, they may report their outcome more positively if they knew that they were in the intervention group, or more negatively if they knew they were in the control group. Unblinded investigators may somehow try and enhance the intervention. Thus, blinding can minimize observation bias. However, blinding is not always feasible, such as when comparing surgical versus medical procedures, when the intervention or standard of care treatment has distinct and known side effects, and also lifestyle interventions. In these cases, it's important to have objective outcomes. Although this is the standard design of an RCT, there are variations. One of these is the factorial design, which is when two or more treatments are evaluated in one study. In the redox trial, study patients were randomized to receive either glutamine supplementation or a placebo, and also randomized to receive antioxidant supplements or a placebo, essentially creating four distinct study groups: the control group that received placebo only, glutamine supplementation only, antioxidant supplementation only, and combined glutamine and antioxidants. The advantage of this design is the cost effectiveness of answering multiple study questions, 2 for the price of 1. However, there is the risk of unintended interactions in the combined group. The crossover design is another variant of the RCT and is when subjects are randomly assigned to a sequence of treatments, so they may first receive the intervention and then they cross over and receive the control, with the outcomes measured at the end of each treatment period. The final phase in an RCT is the follow-up and outcome assessment. Bias can result from differential rates of compliance, withdrawal, or losses to follow-up between the intervention and control groups. This can alter the magnitude or direction of the association between the intervention and outcome. This bias is most common if the RCT is long or there's a complex protocol, if the treatment causes undesirable side effects, or when studying severe or fatal diseases. One can minimize this bias by excluding patients who are likely to be non-compliant, making the intervention as simple as possible, maintaining close contact with the study subjects, and encouraging compliance by emphasizing the scientific importance of the study. Collecting data on withdrawals and other losses from family and friends help to evaluate the effect non-compliance has on the results. Prior to analysing the data, the first step is to compare the study groups to evaluate if they are similar apart from the assigned intervention. If they are similar, as is the case here in the results from the redox trial, randomization has been successful and selection bias and confounding is unlikely. Results should be evaluated using an intention to treat analysis. This is when results are analysed based on original assignment at time of randomization, regardless of whether or not the subjects received the treatment or complied with the protocol. However, this approach is conservative and underestimates the true magnitude of association between the intervention and outcome. This is preferable to an efficacy analysis, which only includes subjects who complied with the intervention. By excluding non-compliers, the benefits of randomization are nullified and the effect measure may be biased. It also limits the generalizability of the results, as it may only be applicable to a subgroup who followed the protocol. In the analysis of a trial with 2 groups and a dichotomous outcome, the most common effect measures are rate ratios, percent relative effect, and risk ratios. Both an intention to treat and efficacy analysis were conducted in the redox trial. This table shows the intent to treat analysis. The effect measure reported was an odds ratio, and this was because a logistic regression analysis was conducted, and this type of regression produces odds ratios, not risk ratios. Nevertheless, the investigators observed an odds ratio of 1.28 for glutamine and 1.09 for antioxidants, both of which did not reach statistical significance because the confidence intervals include 1. This tells us that glutamine and antioxidants, either alone or combined, increased risk of death in critically ill patients. This result was shocking and was big news because, as you may recall, the hypothesis was that these nutrients would decrease oxidative stress and decrease mortality, but it appears that they may be detrimental. You recall from the hierarchy of evidence shown at the beginning of this lecture that systematic reviews and meta-analyses were the only evidence placed higher than RCTs. Meta-analysis is a method of statistically pooling the results of several studies on the same topic in order to identify overall trends and to develop guidelines or policy. This is a meta-analysis pooling the results of 8 previous RCTs of glutamine supplementation and 28 of glutamine supplementation in critically ill patients and 28-day mortality. And the pooled risk ratio demonstrates a statistically significant protective effect associated with glutamine, with a 20% reduction in death. This is opposite to the results of the redox trial, which suggested the possibility of harm. Why? How did this come about? The redox trial was a large, well-designed study. However, the study population were much sicker than patients included in these other studies, and therefore the metabolic effects of these nutrients may have been different and actually caused harm. More studies are needed to try and tease this out. In summary, in experimental studies, the investigator controls the conditions, particularly the exposure assignment. Important design issues in an RCT include sample selection, randomization, the application of the intervention, and unbiased outcome assessments. Major strength of an RCT is the ability to demonstrate causality due to high internal validity from randomization. The weaknesses include limited use, as many exposures we're interested in epidemiology would be unethical to conduct a trial on. There's also the effects of non-compliance and loss to follow-up, and the limits this has on generalizability.